I'm happy to present our next speaker, Dr. Supriya Mohile, who's from the University of Rochester, who's had many roles in the world of geriatric oncology, co-editor of the journal Geriatric Oncology, involved in ASCO and other projects. So, Supriya, thank you.
Thank you. So it's a pleasure being here. I came to Tampa over 10 years ago to visit with Drs. Balducci and Eksterman when I was training in geriatric oncology. And at that time, I remember talking to Stu at a meeting about the first journal in geriatric oncology. That was the first of the geriatric oncology, Journal of Geriatric Oncology set of articles. And it's been really exciting to see such a change over time in cancer and aging education and research. And SIOG has really done a lot for this area. And it also provides an international perspective. And so I'm the chair of the Science and Education Committee at SIOG, and we do encourage new members. It's a great meeting. It's all over the world, which makes it exciting. It's an open forum to present research. And I think abstracts are going to be due soon. And so it's really an opportunity for everyone who's interested in this area to come and interact with their peers. It's also, as Stu mentioned, open to people from multiple disciplines. So given what we do in geriatric oncology, we're excited to have nursing, pharmacy, social workers, therapists, all present at our meetings, because those are who our team members are. And that's what I learned from Dr. Eksterman and Dr. Balducci when I came here 10 years ago to visit with their clinic to see how their model of care and caring for older patients was so different than sort of the traditional model. And we've taken that back. I trained at University of Chicago, and we developed a geriatric oncology clinic there. And now I'm at University of Rochester, and we've tried to mimic the Moffitt model at our clinic there at the University of Rochester. And so, it is such a great opportunity for people from all disciplines to come. I'm a GU oncologist, so I take care of patients with prostate cancer, and I chose that field for a reason. I'm board certified in geriatrics and oncology, and we know that prostate cancer is a chronic disease, and it affects older men for the most part. And so one of the reasons I was drawn to this disease was sort of the interplay of how do you manage a chronic disease in an aging adult. And so I'm going to really focus on a lot of the newer therapies that are out, the data behind the newer therapies for older patients, and also side effects for older patients. So I have one disclosure, but has no relationship to this talk. So I'll discuss the epidemiology of prostate cancer briefly. I'll also discuss castration-resistant prostate cancer, and most of the drugs are in castrate-resistant prostate cancer. So I'll really focus in that area, so advanced prostate cancer rather than, the earlier trajectory of localized disease or biochemical recurrence. We'll discuss prognosis, and I'll review the efficacy and safety of those treatment options in older patients. And then we'll discuss at the end how to sort of sequence therapies or optimize therapies for older patients who have varying level of disease state, so based on symptoms, patient preferences, age, frailty status, et cetera. So we know that prostate cancer is the most commonly diagnosed cancer in men and is the second leading cause of cancer-related mortality in men. Prostate cancer alone accounts for over 1/4 of cancer cases in men, so very common disease. 1 in 7 men will be diagnosed in his lifetime. The median age, as mentioned, is an older age, so it's 70 years, and it's one of the higher age-specific incidences. And there's been, a lot of discussion about how prostate cancer is indolent in older men, and to some degree that is true. There are men who are diagnosed earlier because of PSA, because of screening, that may never be affected from their disease in their lifetime. But with longevity, we're seeing men live longer than ever. And I can't tell you how many men I see in my clinic who were diagnosed in the 1990s, and now it's 2015, and they're dying from their prostate cancer. So the longer that people live, even though this is an indolent disease, it can affect people at the end of life because people are just living into their 90s and are healthy from everything else. So who develops advanced prostate cancer and who dies from prostate cancer? This was a study that showed that patients, about half of the patients are not just older, but are over the age of 75 who have advanced prostate cancer, and that the majority of prostate cancer deaths, 53%, are in men over the age of 75. And as you can see here from this graph, people who live longer or who are older are more likely to die from their prostate cancer than people who are younger. And this is, we see this quite a bit, when people are older, even if they have a high PSA, that is suggestive of a problem with prostate cancer. If they're older and more, quote-unquote, frail with other comorbidities, they don't get appropriate follow-up. There's no follow-up PSA. We just had a man in our clinic who is in his 80s, pretty frail, but even frail men, as Martine showed, can live years. And this man had a PSA of 90 last year and never had appropriate follow-up for that, and then came to my clinic, with an obstruction from his prostate cancer at the age of 93. Those kinds of things still happen commonly to this population because there's sort of a bias that prostate cancer isn't going to be a problem in an older man, which isn't always the case. We know that stage affects survival. So again, sort of thinking about prostate cancer, with our screening, with PSA screening, there's quite a number of men who are diagnosed at much earlier stages of disease and aren't going to ever be affected by that disease. So if you have a 90-year-old frail person coming to your clinic or someone in their 80s, this is where the screening guidelines come into play. If they haven't been diagnosed with prostate cancer and their life expectancy isn't 10 years plus, screening is probably not warranted. However, in someone with a history of prostate cancer, so was diagnosed with prostate cancer 15 years ago, sort of appropriate follow-up is warranted because as people age and are older, the prostate cancer does change over time and can progress. And so it is warranted to follow prostate cancer in men who are older and have been diagnosed. And as you can see, men with distant disease, and this includes men with, I think distant disease here includes men with overt clinical metastases, and probably they've lumped the biochemical recurrence, which is just PSA alone, rise in the localized regional and early distant metastases. But once you have biochemical recurrence, on average, life expectancy is about 5 years. And once you have overt distant disease, on average, it's about 3 years. And so, you can, obviously, distant disease does affect prognosis. I said I was going to talk mostly about castrate-resistant prostate cancer, but I wanted to start off by talking a little bit about androgen deprivation therapy. So androgen deprivation therapy is incredibly common in our population of men with prostate cancer. It is the go-to treatment for patients with biochemical recurrence, or it's used in neoadjuvant and adjuvant setting to improve cure rates for a patient with localized disease. And again, a treatment that is considered benign because it's not chemotherapy, but for an older patient population can be very difficult. And so for patients who are getting radiation treatment, the standard of care is androgen deprivation therapy for as long as you can give it, because it does improve cure rates, especially in men who have intermediate to high-risk prostate cancer. So if you have an older man with Gleason 8 prostate cancer who gets androgen deprivation therapy for a couple years, or someone with biochemical recurrence or early metastatic disease that you give androgen deprivation therapy to, you are subjecting that patient to side effects, and sort of balancing that side effect profile is very important. Androgen deprivation therapy has been linked to physical performance issues, falls, osteoporosis, depression. There hasn't been overt linkages to cognitive issues, but subjectively we hear that our patients do have memory issues. on androgen deprivation therapy. And for patients who have cognitive impairment at baseline, using androgen deprivation therapy may make that worse. Again, not a lot of research in that. There is also observational data that says androgen deprivation therapy is linked to early heart attacks, metabolic syndrome, weight gain. And when somebody is started on androgen deprivation therapy for biochemical recurrence, although there is data for intermittent approach to therapy, most of those men stay on this form of therapy for the rest of their lives. So when we think of castrate men or hypogonadal men, we're actually subjecting men to having a testosterone less than 50, sometimes for many, many years. Again, I have some of my patients in my clinic who are now in their 80s who've been on Lupron for 10 plus years. And so you can imagine that their physical state when they're coming in now with castrate-resistant disease can be more frail because of all the things they've had to feel from the androgen deprivation therapy. We also know that there are a lot of geriatric issues in prostate cancer patients. So it's an older patient population. This is a study that shows about a quarter of patients have comorbidity, disability, and geriatric syndromes coming through newly diagnosed patients. So sort of managing treatments in the context of other medical problems is important, which is why the geriatric assessment is important. There's been some studies that have shown that for people on androgen deprivation therapy, there's quite a few impairments on geriatric assessment. Many are impaired in activities of daily living, instrumental activities of daily living, cognitive issues. The most, I think, impressive issue is physical performance issues, and I think that is a direct link from having the low testosterone. And so physical performance issues here by a validated objective test is about 50% of patients are at risk of falls or who are falling who are androgen deprivation therapy. So definitely a big issue for this population. So this just gives us sort of an introduction, knowing that this is a patient population already on treatment, on androgen deprivation therapy. Once we think about these new treatments, all of the new treatments are on top of androgen deprivation therapy. So it's in the context of somebody on these treatments that we're giving these newer medicines. So I wanted to start off by talking about that. So there's quite a few now. I mean, this has been really an exciting field in prostate cancer. A lot of new drugs over the last three years that are options for these patients. And many are oral, which is great for this population. Again, many are perceived as benign, but in this population of older people on other treatments, nothing is benign. So we have to really think carefully about the risks and benefits of everything we do. Historically, we just had sort of secondary hormonal manipulations that we can use. We know docetaxel has been a standard of care. And then we had some Zometa and samarium and strontium as options. But these drugs, all in blue, I'm going to briefly touch on in terms of the data. So they're all newer drugs that have been available for patients with castrate-resistant disease and are all FDA approved and have data, good data in this population. So just starting off, kind of what are the options, and I'm going to go sequentially through time, so how kind of the drugs were approved by the FDA to try to think about how we would interject some of the new treatments or sequence them. So I'm going to skip over mitoxantrone. We know mitoxantrone was the first chemotherapy that was used for prostate cancer, only had it didn't have a survival benefit. It had quality of life benefit. And given docetaxel coming on the market with a survival benefit, mitoxantrone's really kind of fallen off of what we use for this patient population and isn't commonly used anymore. Docetaxel is very well studied in this population with the TAX 327 trial used with prednisone. And there's good data for patients over the age of 65 and 75. And data has shown that efficacy and safety is pretty comparable to the younger population. Just like any chemotherapy, about 40% of patients have grade 3 to 4 adverse events and are more likely to have dose reductions, but generally the efficacy is not compromised, even though the older patient population may have dose reductions. Some newer data that shows up front, so this is not in castrate resistant, but just showing how we might later on tailor our sequences for castrate-resistant, because more men are now getting docetaxel first line for advanced prostate cancer. So just a couple slides on this. So androgen deprivation therapy plus chemotherapy, we oncologists love to start combining things all the time. So we've used androgen deprivation therapy alone for a long period of time for metastatic disease, hormone-sensitive metastatic disease. And there was a study in Lancet Oncology that showed that docetaxel did improve survival when combined with androgen deprivation therapy in the first-line setting. There were patients that were older in this trial, and this was an advanced advanced cancer population with bone disease and lymph node positive disease, good performance status. But again, 6 cycles of docetaxel up front improved survival. And so many of our men now who may get hormone therapy with docetaxel and are coming castrate resistant later have already received docetaxel, which may push that out of favor as a first-line metastatic option. So another drug that is a tubulin targeting drug, which is cabazitaxel. It's also a microtubule inhibitor, promotes assembly and stabilizes the microtubules and inhibits cell transport. So cousin, so to speak, of docetaxel. The TROPIC trial was a phase 3 trial that randomized patients who progressed on docetaxel to cabazitaxel plus prednisone versus mitoxantrone. This is one of the first non-docetaxel drugs that became FDA approved for advanced prostate cancer. Unlike other disease types, these trials do include a good proportion of older patients because, as I mentioned, the majority of people with this disease are in the older age ranges. So we have good data because, for example, in this trial, there was quite a few patients who were over the age of 65. Almost 60% of patients were over the age of 65, which is reasonably reflective of the population. However, the trials still don't, and you'll see this throughout my talk, don't talk as much about comorbidities and none really include geriatric assessment. So we would presume that the older patients included in these trials are fit because of the sort of clinical trial criteria that are in place. But many are older. Most are good performance status. In this trial, again, an advanced cancer patient with about a quarter of the patients having non-bone and non-lymph node metastases. Cabazitaxel did improve survival with a median overall survival in the treatment arm of 15 months versus the mitoxantrone arm of 12 months. And so cabazitaxel was one of our first drugs that was approved for use in patients previously treated with docetaxel with a hazard ratio of 0.70. Overall survival benefit was consistent across subgroups. There is some data now to suggest that some side effects are more common in older patients, and the two that are common are febrile neutropenia and diarrhea. And so really closely monitoring these patients are important. We have our patients on cabazitaxel at least phone in or are seen almost weekly because the diarrhea can be pretty severe, and these patients are the most likely to go into the hospital from the diarrhea. And we also do consider prophylaxis with GCSF for this patient population. Again, a compassionate use program in Europe showed similar efficacy and safety and recommended prophylactic GCSF for the older patient population. So the next drug is a more novel drug here, abiraterone. So abiraterone was approved in castrate-resistant patients with prostate cancer who progressed on docetaxel initially. And abiraterone works by decreasing the production of the protein cytochrome P450 in the liver, which the body uses in the production of testosterone. And the pivotal phase 3 trial included abiraterone, which is 1,000 grams per day, so four pills a day with prednisone or to placebo and prednisone. Again, the majority had progressed on docetaxel chemotherapy. Again, quite a few patients, and I love this study because they actually report out how many patients were over the age of 75, other than 65. So I like to highlight that because that's for this patient population, it's great. And this study did do that, which is wonderful. And I bet Stu reviewed it. No, because he probably, somebody asked them to do it, I'm sure, who reviewed it. So 1/3 of the patients were age 75 and over, which is pretty cool. Again, this is the post-docetaxel group. So bone metastases, no metastases, liver metastases were common. Most had good performance status. Many had progressed on multiple chemotherapy lines. And abiraterone did improve survival in this patient population, 14 months versus 10, very similar to the cabazitaxel data, several months survival benefit in this population. So abiraterone was approved for patients treated with docetaxel originally with a median overall survival of 14.8 months versus 10.9 months. In terms of side effects, adverse events were similar in both groups, but there is this unique side effect of mineralocorticoid access with hypokalemia, fluid retention, and hypertension that's more common on patients with abiraterone. And liver obviously can have liver issues. You can get liver transaminitis. And so there's caution in the patient population with comorbidities with hypertension and cardiac disease because of the fluid retention. But in general, the efficacy and safety is similar for patients over the age of 75, and there was a separate paper that looked specifically at this population that showed that. So very good data in fit older adults with abiraterone. There has been expanded FDA approval for abiraterone for patients prior to chemotherapy, which is pretty exciting. So patients who have castrate-resistant disease before chemotherapy can now have abiraterone as an option. This study actually included patients with asymptomatic or mildly symptomatic disease. So these are your PSA rising, progressing bone metastasis, but no symptoms. And again, 1/4 of the patients were over the age of 75 in this study in addition. And in addition to improving both PFS, and now we have data on overall survival, it actually improves quality of life. So they looked at interference by pain. So abiraterone prior to chemotherapy delayed sort of the onset of symptoms from prostate cancer, which is a great benefit to this patient population. Moving on to our third drug, so enzalutamide, another new, more novel drug for advanced prostate cancer. This is an oral androgen receptor antagonist, similar in mechanism to bicalutamide or other anti-androgen agents, but is much more powerful at blocking the androgen receptor. And the firm study randomized 1,200 patients who again, this is in progressing on docetaxel patient population to enzalutamide or placebo. What's unique about this drug compared to the previous drugs I discussed, docetaxel, cabazitaxel, and abiraterone, is this drug does not have to be given with steroids, which is for someone who is having side effects from the steroids or is diabetic, may be a benefit. 1/4 of the patients in this study were over the age of 75 in addition. So this inhibits the binding of the androgens to the androgen receptor. So the firm study, this again is in a post-docetaxel group, improved survival with a hazard ratio of about 0.63, 18.4 months versus 13.6 months. So pretty impressive survival benefit. And the FDA then approved enzalutamide for patients previously treated with docetaxel. Adverse events are pretty similar in both arms. I find that this drug is very well tolerated in older patients, even my very frail older patients. And I think this drug is better tolerated than abiraterone because I have patients complain about fatigue and the sort of dizziness you get with mineralocorticoid access with abiraterone, whereas I have less patients have problems with enzalutamide. But fatigue and diarrhea are common in this also and are more common in patients over the age of 75. Seizures are uncommon, but the seizures are a side effect of this drug. Less than 2% of patients have seizures with this, but are likely associated in sort of consistently among studies. So once you know it works after docetaxel, how about before chemotherapy? So like abiraterone, there's now data to show us that enzalutamide can be used before chemotherapy. So about 1,800 patients with asymptomatic or minimally symptomatic advanced prostate cancer randomized to enzalutamide for placebo, and enzalutamide improved survival. Do I have a slide on this? Yeah. What was interesting about this was that they also looked at the median time to needing chemotherapy, and getting enzalutamide prior to chemotherapy delayed the need for chemotherapy. So for patients who, in this population, who say, you know, doctor, I'll do whatever you want, but I'm not going to do chemotherapy. I've always told myself I'm not going to do it. I'm 89 years old and I don't want chemotherapy. These are really great options before chemotherapy because they do delay the need for chemotherapy. So fatigue and joint constipation and joint aches and diarrhea and edema can be more common in the treatment group, but again, reasonably well-tolerated drug for this population. So it showed the median time until initiation of cytotoxic chemotherapy was 28 weeks in the enzalutamide arm versus 10 in the placebo arm. And again, also improvement in quality of life and delayed to skeletal-related events in this population. So I reviewed adverse events, but about seizures, again, very uncommon, but in this population, especially in patients with a seizure history, it's important to counsel patients on this so they're aware of seizures, especially people who are driving, so that they're aware that this could be an issue. So moving on to Sipuleucel T or Provenge. So this is a unique drug and a unique mechanism. It's a vaccine actually for prostate cancer. It's an autologous cellular immunotherapy that activates the immune system against prostate cancer. It basically takes antigen presenting cells from the patient. It's cultured with a protein from the prostate cancer and sort of given back to the patient. And so in this study, which is the IMPACT trial, looked at patients who had asymptomatic or minimally symptomatic disease. Patients could have received docetaxel, but again, not a lot of symptoms in this patient population. Randomized to Sipuleucel T, which is about 3 treatments versus placebo, and evaluated overall survival. And the median overall survival was 25.8 months in the Sipuleucel T arm versus placebo. So it's a unique mechanism. It's the first active immunotherapy to improve survival in patients with advanced prostate cancer. It's a vaccine, so it's not a pill, it's not a chemotherapy. Some patients really kind of value this and are very interested in not being on those kinds of treatments. It has generally a favorable benefit to risk profile. Most of the issues are infusion-related issues. There is some sort of suggestion that there could be stroke-related issues with this, although that hasn't been officially borne out from the data. It is quite a bit of work to get patients on these. You have to be at a very specialized center. We do it at the University of Rochester, but our patients go to Buffalo to get their to get their cells removed, and then they're back in Rochester to get infused. So it can't be done in sort of the community. It has to be done at specialized centers. But it is an option for patients who have asymptomatically or minimally symptomatic disease. The other unique thing about this is that the PSA goes up, and if you do scans, they probably get worse. And it doesn't mean this is not working, because even though you can see objective progression on scans or by PSA, there is a survival benefit. So we're not 100%, we don't really understand that, but with a lot of the immunogenic drugs or vaccines, like even in melanoma, that can be the situation. So we really have to counsel patients that your PSA is going up, but we're not going to stop the treatment. We're going to carry it through. And that can make people very nervous because they've been sort of watching their PSA their whole lives. It's also extremely expensive, and so appropriately selecting patients for this is important. So those were the drugs, sort of the active cancer drugs. I'm going to talk about one more, radium-223, but I wanted to pause to talk about bone disease in prostate cancer, because most prostate cancer metastases are in the bone, and that's one of our big quality of life issues for our patients. So in the castrate-sensitive non-metastatic arena, There are treatment-related fractures, so men on androgen deprivation therapy get osteoporosis, and so they're at high risk for fractures from osteoporosis. Compression fractures are common, so we often see patients who have rising PSA and all of a sudden have back pain, and we're trying to determine if they have overt disease from cancer or is it compression fractures from the osteoporosis, and we have a lot of this diagnostic dilemma trying to figure that out. And so it is very common to get compression fractures. And then you have castrate-resistant disease. It's non-metastatic. This is PSA rise only. And then disease-related skeletal events when the disease becomes castrate-resistant and it's progressing in the bone. And so denosumab is a rank ligand inhibitor. I'm going to actually go to the mechanism here. So here's the rank ligand inhibitor. So how does that work? So the rank ligand does mediate osteoclast differentiation and physiology and activates the osteoclasts to cause more problems in the bone. And denosumab inhibits the rank ligand inhibitor. And so we have pretty good data in patients with prostate cancer, both in men on androgen deprivation therapy, that using denosumab at 60 milligrams every 6 months, and this is actually called Prolia, is useful in improving bone mineral density and lowering the risk of vertebral fractures. And then we have data compared to zoledronic acid that shows that denosumab can delay the onset of bone metastases in men with castrate-resistant prostate cancer when used monthly. And so an option for patients with bone disease. And this is the primary analysis of the second study that I mentioned, showing the delay. It's not a survival benefit, but it delays skeletal-related events as defined by increased pain, compression fractures, needing radiation, etc. So it delays bone problems. And so a lot of insurance companies have argued, because of the expense of this drug, that it may not be better than zoledronic acid, even though the data shows that there's a delay in that because it's not an overt survival benefit. So it depends on a lot of, in our country, it depends a lot on insurance and whether or not they would allow this to be used over zoledronic acid. But there are some patients who benefit from this, and that's your patients with renal insufficiency. So this can be given in patients with renal insufficiency with good monitoring of electrolytes, whereas zoledronic acid is much more difficult in patients with renal insufficiency. Both zoledronic acid and denosumab have similar rates of necrosis of the jaw. Denosumab has higher issues with hypocalcemia, and I've had a lot of my older patients have hypocalcemia problems because no matter, you have to really do rigorous counseling on calcium intake, and even though you're asking them to do it 3 times a day, calcium is really difficult for older patients due to the constipation problems. And so if they're not taking calcium, it can be an issue. The electrolytes can be an issue, and I've had to take patients off denosumab as a result of calcium problems. So really counseling for the calcium is important. So radium-223, I believe this is the last drug I'm talking about, is a sort of a novel drug, or novel mechanism of action treatment, a radiopharmaceutical approved for treatment of castrate-resistant prostate cancer. And it's an option for first-line or post-docetaxel. The median age was 71 on the phase 3 trial, and most people had good performance status. The trial, the Simca trial, randomized patients with multiple bone metastases and no visceral metastases, so patients could not have liver metastases or lung metastases on this trial. And patients who were after docetaxel mostly, but they did include patients that, quote unquote, were unfit for docetaxel, although that wasn't really measured by any sort of assessment or criteria, so it's sort of physician discretion. And they randomized patients to radium-223 or placebo. And what they found was that there was an overall survival benefit. So for the first time, a radiopharmaceutical for this disease showed a survival benefit. So certainly an option for patients with bone-only metastases, and also having some symptoms from bone, but generally feeling okay. Adverse events, again, I think there's a perception of this that it's not as hard, but it does have side effects. There is bone pain issues, diarrhea issues, and anemia and thrombocytopenia issues. with using this. And so if you're thinking about chemotherapy in a patient, you may not want to use this till later because it does cause some myelosuppression. If you use it too early, that may, in an older patient population, limit your ability to give chemotherapy later. And so diarrhea and bone marrow suppression are your biggest toxicities here. But improved median survival, delay the time for the first skeletal-related event, and some toxicities, generally well tolerated, but diarrhea and myelosuppression. So thinking about sequencing therapies with all our new therapies now, I think for this population, the biggest thing that I'm thinking about with the patient is how to avoid chemotherapy. So no matter what, chemotherapy, does improve survival, but but has more toxicities in general than some of these other newer agents. So if you're thinking about a patient sort of through from the beginning, and you're going to be caring for a patient for 10 years with prostate cancer, you kind of want to think through your sequences as soon as that patient becomes castrate resistant. How are you going to sequence the therapies? Because you don't want to use one and then realize you couldn't use the other. So you really want in your head think, well, I'm going to use this first and this second and this third and this fourth because they all have a survival benefit. And so for clinical metastases that are castrate, the options pre-docetaxel include Sipuleucel-T, abiraterone, and enzalutamide. For clinical metastases that are castrate, your first-line chemotherapy is still docetaxel. For bone metastases, at some point, radium-223 can be considered. It can be considered potentially after these for patients who are not candidates or do not want chemotherapy. Or it can be considered after chemotherapy for patients you're going to give chemotherapy to ultimately. And then after docetaxel, you have cabazitaxel, and if you haven't used abiraterone or enzalutamide, there are options. But in this patient population, we're tending to use abiraterone and enzalutamide first before chemotherapy. And so we're educating our urology colleagues and other people out in the community. Please refer patients, if you're not familiar with these drugs, even if your patients say they don't want chemotherapy, we've got new options for them and can help, make them live longer and feel better. So please refer them because we still tend to see patients, depending on who's seeing them earlier on, very late in the game. So earlier in the game, using abiraterone and enzalutamide before they're symptomatic is really a great idea because it does improve outcomes. So I have a case study here. So I think, are we going to use the audience response things or no? I don't know. So 86-year-old with metastatic prostate cancer, seeing for the first time, previously followed by urologist. And I just saw this patient. Actually, I lowered the age. My patient in real life is actually 90. Diagnosed with Gleason 7 prostate cancer, and I felt like people wouldn't believe me, so I ended up lowering the age. And I just saw him on last week and I told him I thought of a case with you. So Gleason 7 disease, approximately 6 years ago, started on Lupron 3 years ago. He was recently treated with bicalutamide, discontinued several months ago due to a rising PSA. Disease is widespread through the bones, and a recent bone scan shows progression with new lesions in multiple areas. His disease nadir to 6, but is now 20. He is castrate, so checking the testosterone is always important when someone progresses after androgen deprivation therapy because you want to make sure they're still castrate. What we do in our clinic is we really do consider health status to make a decision about the next treatments. And so here are the things that one could consider when thinking about prostate cancer. So thinking about the sequencing of the therapies, we talked about symptoms. So some therapies, if you have a pre-docetaxel, pre-chemotherapy patient who hasn't received chemotherapy and they're very symptomatic from their cancer, then abiraterone and enzalutamide are likely not the right options for them because that data was in patients who had not that many symptoms. So you really want to go towards something like chemotherapy, which is more likely to help with symptoms from the cancer. So symptoms are very important. Luckily now, if people are being followed, we usually see patients before they're having symptoms. I mean, it's rare for us to all of a sudden have a patient that has a ton of symptoms without knowing that's about to happen. So we are following people, and I usually have patients, follow with scans every 6 months, that I see their disease progressing before they develop symptoms that are significant. We want to include patient preferences, and we standardly use a geriatric assessment in our clinic to help make decisions regarding therapy. So this patient had pain. So he had several ages of pain that were bothering him. But when we did more discussion, he attributed the right hip pain to arthritis, and it's been chronic. And he had some scapula pain, but it wasn't very significant. He wasn't using a lot of pain meds. So he, although had some pain, it wasn't necessarily related to his disease, much more arthritis related. He had intact function, IDLs, cognition. He lived in an independent living facility. He was caregiving for his wife with dementia, who has pretty significant dementia. Daughter, very supportive, and drives to the appointments, but doesn't live with them, obviously. He does not drive himself. His daughter brings him to his visit. He does have some physical performance issues, is a fall risk, hasn't fallen, but uses a cane to walk. He's not depressed or anxious. He is on dialysis, and he's probably the healthiest dialysis patient I've ever seen. So he's been on dialysis for the last 8 years, using only metoprolol and baby aspirin, so very few medications. And so if you look at this guy seems pretty frail based on his age and his dialysis function, yet when you meet him and you think about his geriatric assessment, he's pretty functional. He's caregiving for his wife. He isn't falling. He has some issues that we have to be careful of, but he's starting to have issues with his prostate cancer, and he's lived on dialysis, so his life expectancy still could be years outside of his prostate cancer. And so he's going to have symptoms from his prostate cancer if it's not treated. And so this is somebody that, although is vulnerable sort of on the frail end, would benefit from cancer treatment. And these are the kinds of patients that aren't always referred to oncologists because they see the age and they're on dialysis, and they presume that there's nothing we can do, whereas there's a lot we can do for this patient now. So the patient would like to avoid chemotherapy, but would consider chemotherapy. So that, if you think, doctor, I should get chemotherapy, I would do it. And of course, I'm not going to give chemotherapy to him, given that he's on dialysis and he is close to being 90 years old. But we could consider some of these other drugs. So, thinking about what the options were, abiraterone, enzalutamide, docetaxel. Well, I wouldn't give him chemotherapy, but these are the other drugs that are options. We discussed enzalutamide and abiraterone, and we talked to our pharmacy. I know there's some. I think there's some pharmacists in the audience, and I actually, being careful, I tend to sort of reduce the dose. There's no data for this, so I hope but I reduce the dose for the first month just to see if people can handle it, and then I kind of go up with the second month. And my pharmacy colleagues were like, "Why are you decreasing the dose? It's completely safe to give these drugs with patients with dialysis." He received abiraterone and did well with full-dose abiraterone for almost a year and a half, and just progressed and is now on enzalutamide, doing well on full-dose enzalutamide. And so I've talked to them now, because if he progresses again, I don't think I would give him chemotherapy. I think the risk-benefit ratio would shift. And I don't think he would want chemotherapy. But we've now extended his life expectancy a couple years, and he has had no symptoms from his prostate cancer and has had very good quality of life, no change in his quality of life for the last couple years. And so there are very frail patients who would benefit from these treatments. And so it's really sort of thinking through those options. So in general, the newer treatments have acceptable efficacy and toxicity in fit older patients. I do think being careful in your more vulnerable and frail population is important. We don't have a lot of good data about safety and efficacy in patients like the one I described, the patients that wouldn't have necessarily been included on the clinical trial. But just anecdotally, we've been treating these patients, and generally it's been working. It's not out of the norm, and I've treated many older patients who are frail with these drugs, and they've done well. including thinking about selecting and timing therapies, health status, including ability to comply. A patient with cognitive impairment, that every time he brings in his bottles, he's taking his abiraterone wrong. So we've had home nursing go in, and it's no matter what we do, we can't convince his family that he shouldn't be filling his pill box himself. So it is important to sort of thinking about that with these oral drugs. Level of symptoms, presence of bone metastases and visceral disease, and patient preferences for chemotherapy. So thank you very much.
Any questions?
Phenomenal talk. As somebody who hasn't primarily treated prostate cancer in well over a decade, I think you just gave me not just a geriatric review, but
I've just recertified for my boards. I wonder, this is
I pity you. Fortunately, I've been grandfathered.
Good, you're lucky.
So their age does have its privileges.
Unfortunately.
It's hard.
Fortunately. I marvel at the fact that docetaxel is relatively or seemingly well tolerated in this elderly population. Of all the tools in my therapeutic tool chest, it's the toughest drug I deal with. So what's particularly in the elderly, particularly in a prostate lung, anything above the diaphragm.
It's weird because I actually see lung cancer patients through referrals through my geriatric oncology clinic, and I agree with you. I think docetaxel is harder in the lung cancer population than it is in the prostate cancer population.
What do you attribute this difference?
It may be pre-treatment because you're using docetaxel usually after other treatments, whereas this is first line for prostate cancer chemotherapy-based treatment, so that may have something to do with it. I've had very reasonably frail older adults be on docetaxel for greater than a year. With a 3-week, I usually don't use full dose. It's 60 milligrams per, and you can get benefit with that too. And it's Q3 week we use for prostate cancer, whereas you may be using weekly. Use Q3 week too. So I think it's maybe the first versus second line issue. But I agree with you. I do think docetaxel is harder in the lung cancer population.
The Japanese have typically used that 60 per ml. When I talk about lung cancer, you'll see a lot of data for that. The second comment I have, I'm not aware of any other cancer where you have a second-line taxane salvaging folks who've failed whose disease has progressed on a first-line taxane. Cabazitaxel, for those who aren't aware of it, has absolutely failed in second-line small cell. Topo T can actually look better.
But it works in
speculation why
it's
that
hard.
is?
So when you're talking about, I think cabazitaxel is much harder. So when you use docetaxel in this population, then use cabazitaxel, it's much harder. So I try to avoid cabazitaxel unless I have some are super fit or in the young old, 65, 70, 75 plus. It's a tough drug.
I was just going to add that one other reason why you may see the lung cancer, a difference between the tolerability of docetaxel in the lung cancer population and the prostate cancer population, is Spareboom and colleagues actually found an interaction between castrate resistance hormone levels and the rate of metabolism of docetaxel. And it's been correlated with PK and toxicity. Both show that there's less toxicity and it's metabolized faster. So, so there you go.
Ludovica, we know how you feel about castration.
Look on to all your lung cancer patients, and they'll tolerate it better.
I just want to make one more comment. Enzalutamide is a very interesting drug, being a sort of powerful androgen receptor blocker. I didn't talk about it in this talk. I hate androgen deprivation therapy as much as Ludovica does. So, it may be that using some of these drugs in lieu of androgen deprivation therapy may be beneficial. And there's studies looking at enzalutamide for hormone-sensitive disease, phase 2 trials. We actually have a investigator-initiated trial open at University of Rochester in Wisconsin, looking at patients who we don't want to really use androgen deprivation therapy for to see if enzalutamide is better tolerated. And so hopefully maybe some of these drugs can be used up front and even replace replace potentially androgen deprivation therapy. I don't think any of the other drugs could do that except for enzalutamide, but.
Yeah, I have a question. You said that, and I don't use denosumab to prevent bone metastases. It's not approved for that. So how
It's approved for delaying skeletal-related events and
Skeletal-related events, but
Yeah.
not bone metastases.
right. That's what
I know,
radium.
but your
223.
slide, and that's what I
Oh,
caught my
well, I
attention.
misspoke then. I apologize. Yeah, you're right.
It's a little. That was a little shocking.
Yeah.
Okay, so you
Yeah, it's
meant-
approved to delay skeletal-related events.
Right, but not bone metastases.
Correct. Mm-hmm.
Okay, just so that's clear, because I
Yes,
figured
you're
people-
correct. If I said that or it was on a slide, I misspoke. You are absolutely correct.
I just have a quick question because it's coming up at the VA in the fellow clinic, and that is when should I be fighting the good fight to get something like abiraterone, which is expensive, approved?
Oh, you should be
And
fighting it.
when might it be reasonable to use the cheap stuff, which is ketoconazole?
Oh, I don't. You mean pre-chemotherapy? You should
Pre-chemo.
have no issues with insurance approval at this point. So I mean, I don't know how the
I think
VA
it's
works.
a little bit different. I'm
It's-
just asking clinically speaking.
Ketoconazole has
how
no
would you
survival
approach-
benefit that we know of, and it's much less tolerated. There's drug interactions, there's nausea, it's fatigue, I personally think if you have a survival benefit with abiraterone, ketoconazole doesn't. It's
So
not
fight the
even.
good fight then.
I would fight it. And especially if your patient is not a chemotherapy candidate. And so what I usually do, because we've had these issues, I'm sure it's not the same as the VA issue, but we've created a whole pamphlet of why the patient is not a chemotherapy candidate. So if you could have geriatric assessment in there. You could say this patient is not a chemotherapy candidate because of X, Y, and Z. And if you can sort of prove the point that they're not a chemotherapy candidate or are not a ketoconazole candidate, then potentially they'll give you abiraterone, but I don't know. That's what we do.
Other questions?
And then you mentioned, first of all, I have a 100-year-old patient with prostate cancer he did not need abiraterone yet. Has been around since, has been doing very well on androgen deprivation for more than 15 years. Was diagnosed with bone metastasis and does not speak a word of English. He's Cuban and he travels by streetcar, comes here and go back. And so it's really an interesting case. But you mentioned you treated that patient, the patient you mentioned with enzalutamide after abiraterone, and enzalutamide worked because I think it's very controversial whether. All of us do it, but
Yeah. I don't know that I think there is sequence data. I think even in JGO for older patients, there's some sequence data with abiraterone and then enzalutamide or vice versa. I do think there's less efficacy if you use the other one second, but there is some efficacy still, and we need more data about that. But we all do. It's like any other oncology field. When you have all these drugs out there, the sequencing is always unclear.
And assuming that you have some patient who can tolerate the financial toxicity of the combined treatment, have you ever used the combined treatment?
You mean abiraterone plus enzalutamide?
Yeah.
So there is a study through the Alliance. I don't know where it is yet. I think it's crazy. So I don't know what will happen if it shows
Why
survival
do you think
benefit.
it's crazy?
But you don't think it's crazy?
I'm
I
asking.
think if you have these good drugs, the issue is that when they do the control arm, they don't test the sequence, right? So how do we know the combine is better than the sequence? And I think it's hard to design a trial like that, and I do think the financial toxicity and physical toxicity of the drugs is going to be significant. It's probably 8 pills a day that these people have to take. I just don't, for our population, the 70, 75 plus, I'm not sure it would be warranted. For younger patients or to replace androgen deprivation therapy, it may later on, but I don't think for this population it makes sense.
Thank you.
Yeah, and people are really focused on quality of life, and I'm just, I don't buy it.
We'll take one more question.
All right.
So you raised a very interesting issue, which actually extends beyond prostate cancer. Older folks on dialysis and reluctance, maybe because of his age or his health set beliefs that he wouldn't get docetaxel. I've actually successfully given this drug to dialysis patients, one of the more compatible drugs. I've reduced the dose again empirically and been very pleased by how well it works. I wouldn't toss it out
Yeah, that's good.
empirically.
I think it may come up if he becomes symptomatic from his cancer. He may choose to try it, and I would be willing to give it to him.
After listening to Dr. Balducci's 100-year-old prostate cancer patient, it occurred to me that we ought also to talk not only for prostate but all other geriatric cancers about people who are frail, homebound, assisted living, have an active cancer, and we tend to identify them in the slides, but we do not take the next step as to what do we do with them, what is our advice, and how do we educate the community that this is not therapeutic nihilism or ageism, but it is upon advice that it is that the actuarial data show that the life expectancy with this frailty and these comorbidities are so bad. But we don't do that. We just do what treatments are recommended or available. And I think that is a part of geriatric oncology.
I completely agree. I think you just, in a short sentence, a few minutes, just summarized the whole field of geriatric oncology. So that's what I think the main goal is. There have been efforts through the Cancer and Aging Research Group working with the NIH to have a series of conferences. They're called the U13 conferences, and there's some white papers that have been published. I think we do have to include the population you mentioned in clinical trials, and we have to think differently about our infrastructure for clinical trials. And I hope we'll get there. We're still, obviously, it's an uphill battle.
I mean, one of your slides, you showed a study from the New England Journal of Medicine. It had almost 1,800 older patients on study, and the study did not include any zero geriatric
None of them did
assessments or anything. And you look at that and you say, in a sense, what a waste. You had the opportunity. Well, maybe not, because these are clinical trial patients, so what Kanti's saying is so true, but at least it gives you a starting point, gives you some information. We've tried, I know in the Alliance, we were talking this morning, we had once proposed, when they were doing organ dysfunction trials, to do a study on looking, the organ dysfunction was the patient's frailty or vulnerability. And it couldn't get through the hierarchy, but people have to do these kind of studies of the frail and vulnerable, which are very difficult in clinical trials. So anyway, we're right on time, so we're going to have a short break, and thank you very much.